Budget Subcommittee 3 started. I understand a Republican caucus was called, so we'll be joined shortly by Senator Stone. Senator Monning was called into a meeting with the Pro Tem. He'll be joining us, but we will go ahead and honor your time and get started. We've got a pretty lengthy agenda today. Hopefully everybody has a copy, all 56 pages of it. So let's go ahead with the first panel. Department of Managed Care. We have 5 areas we'll touch on. We'll start with the overview, move into the federal mental health parity rules, enrollment in individual market, large group claims data exposure, and Delta Plan's medical loss ratio.
Good morning.
Good morning, Ms. Roulard.
How are you today?
Fine, thank you. Thank you for being here.
Madam Chair, want to give you a brief overview of the Department of Managed Healthcare's program and budget, but first let me introduce Marta Green, who's our Chief Deputy Director. She's here to help me answer anything that I can't answer.
Excellent. I can't imagine what that would be, but excellent.
So, of course, you're familiar with the department, but our mission is to protect consumers' healthcare rights and to ensure a stable healthcare delivery system. The department licenses and regulates more than 125 full-service and specialized health plans that provide coverage to about 22 million Californians. The department regulates about 91% of the commercial healthcare market, and our proposed budget for 2015-16 is $68.2 million and 417 positions. The department is funded by annual assessments on health plans, no general funds. We also do get some federal grants and reimbursements. I'm not going to go into all of the programs in any great detail because you know we have the help center and we license plans and we enforce the law and all of that. So you were asking about how we engage stakeholders, and as a lifelong consumer advocate, I have been involved in many stakeholder meetings, both outside, and I'm pleased to be able to sponsor these inside the department. It's one of the most important components, I think, of what we do. So there's a number of stakeholder committees, work groups, and forums that the department sponsors to have meaningful engagement with our diverse stakeholders. So first, the Financial Solvency Standards Board was created in statute and advises the department on matters of financial solvency that affect the delivery of healthcare services, and they recommend financial solvency requirements and standards related to plan operations, plan provider contractual relationships, and operations and transactions. The board meets quarterly. In fact, we just met on Wednesday, and its meetings are open to the public. We also have a quarterly consumer advocates meeting with a broad range of advocates that include Health Access, Western Center, Consumers Union, Congress of California Seniors, and CPEN. These meetings are an opportunity for me to interact one-on-one with the stakeholders, for them to raise issues to me directly, and for me to hear from them about what their concerns and any emergency issues are. These are not open to the public. They're really for me to have that frank conversation with the consumer advocates. We also have recently, in the last year, started a mental health stakeholder work group that was started around the implementation of the Federal Mental Health Parity Act. And we're meeting quarterly as the department implements the federal mental health parity requirements and keeping them informed on what we're doing, how we're doing it, and getting their engagement and feedback in that process. Also, another area in mental health work group that we have is the Consumer Provider Plan Agency Mental Health Work Group. Started in 2007, which was really an opportunity to bring the various interest groups together to identify barriers to mental health services, discuss root causes, and collaborate on best practices to improve access to mental health care. Then on the plan side, we have a quarterly meeting with the plans. We call it our licensing roundtable, which is an opportunity for licensing staff and our financial oversight staff to talk with the compliance staff of the plans about how we do our business, what we're expecting from the plans on whatever the issues of the particular time are, whether it's mental health parity issues or network adequacy filings or whatever it may be. So those are our standing stakeholder opportunities, but as new laws are passed and we're implementing them, we engage stakeholders, and more specifically recently around SB 964, which was signed in September of 2014, that requires us to annually review and assess all provider networks with the plans, full service and behavioral health networks, and that's across Medi-Cal, commercial, and the individual markets, and also to standardize health plan reporting of timely access methodologies. So that's an ongoing process. We've had 4 stakeholder meetings, one with each of the plans, the providers, and the consumers, and then one with all of them to announce how we were going to proceed for measurement year 2015. And all of our methodology for that survey is on our website, and so as a result of that engagement with the stakeholders, I feel like we have a really good process for, at least for the current year. And then we're going to talk about the medical loss ratio for dental plans, but that's another area that we've engaged the stakeholders in how and what types of information we want to collect from the plans in order to evaluate where the premium dollars go. So with that, I'll ask you if you have any questions.
Is the legislative staff or the legislature legislative staff, I should say, included in any of those stakeholder engagements, or particularly those kind of ongoing work group meetings?
Yeah, the leg staff are notified about several of those. The consumer advocate meeting is as I said, closed.
Right.
But when we have work groups that relate to legislation, yes, we are going to be and have been in the past invited leg staff.
Okay.
I know we slipped up recently, but that's not going to be a problem in
Excellent.
the future.
That would be helpful to us as members, that they are included on an ongoing
Sure.
basis. Thank you. Finance or LAO? Any public comment on the overview of the department? Okay, we'll roll right into, I'm sorry.
Right.
Senator Stone,
That's right.
welcome.
Thank you. Sorry I missed part of your presentation. Appreciate you being here today.
No problem.
The 24-hour help center, which I embrace that you do that. Can you tell me how many calls you field in a year's time? Is it widely used?
It is widely used. I have the deputy director for the help center here with me. I don't have the exact numbers off the top of my head, but yeah, 80,000.
It's about 80,000 contacts in combination between phone calls as well as written contacts.
And I would imagine that probably one of the top 3 reasons why people call is because of delays in prior authorizations and allowing for certain procedures that are ordered by physicians. Is that?
That is a significant category. I don't know if I would call it a majority, but that is a category. There is also requests for independent medical review if something is delayed or denied, as you're describing, or maybe they're having difficulty getting into a provider to begin with. It could also be that the quality of care that they received was not up to their standard. It's a wide variety of issues, but we'd be happy to get you kind of a breakdown of the categories.
I'd appreciate that. One of the biggest complaints that I get from my constituents is that, the doctor will order a CT scan or a MRI, and it could be something potentially life-threatening. And in some cases, there are delays. They have to go through the bureaucratic morass of, ensuring that it qualifies for funding for within that particular plan. And my concern is that we have people that are getting delayed services because of, frankly, money. What is your agency doing to do what it can to alleviate these delays? And if you do get complaints, how do you proactively go to the plans and say, withholding this procedure is not in the best interest of your patient. We need you to, follow through with the doctor's orders. Right.
When there's an urgent need for a specific service that's been delayed or denied, we do have a process for expediting that through the help center process. And with regard to what we do with the plans, we do look in the data that we collect from consumers who call, we look for patterns and issues that come up. And the help center has direct connections with many people within the plans themselves to get matters resolved quickly, like within a day. We call that our quick resolution process. And then on the ongoing work, we do medical surveys every 3 years of the plans to look at how they handle grievances and appeals, how they deal with consumer issues, are they processing them properly and timely and all that. So when there are issues that come up, we do address those with the plans either through the regular process, or if it's something really critical, like last year when we were having all these problems with providers who were being listed in directories that turned out not to be available. We do what we call a non-routine survey, and we can go in and investigate a particular issue and find out what's going on and then take enforcement action when appropriate.
And where do you publicize your 24-hour phone number for consumers? Where do they find that number?
The best way that they find out is through the letters they get from their health plans that when they've been denied or had a service delayed or modified. And there's statutory language that's required in those letters to say you have the right to an independent medical review. And historically, the Office of the Patient Advocate has promoted the Help Center, but their responsibility for that has gone away. So it is a challenge, frankly, to get the word out to people about the service because they really need to know it at the time when they have the problem. And if we were to, try to do a big, expensive publicity campaign, people it won't register with them until they need that service, which is why we work with the legislators and your legislative staff. So when you get issues, you can refer them to us and we address those.
I appreciate your answers. And when you have a chance, I'd like to get some more information on your quick resolution process.
I'll be happy to meet with you about that.
Thank you for being here today.
Thank you very much, Senator. Let's move on now, Ms. Willard, to the federal mental health parity rules, page 5 of the agenda.
All right, so you had several questions about this, so briefly I'll do an overview and then respond to the questions.
Please.
The department requests 11 positions, 5.5 permanent and 5.5 two-year limited term, to address workload associated with conducting back-end compliance reviews and medical surveys of the health plans, subject to the Federal Mental Health Parity and Addiction Equity Act. I'm just going to call it the Mental Health Parity Act from now on. We have 2 additional positions being requested starting in 16-17, providing 7.5 permanent positions ongoing. Our request in this budget year is for $1.86 million, $2.2 million for fiscal year 16-17, and $166,000 for fiscal year 2017 and ongoing for clinical consulting services to do them for mental health plan surveys and for expert witness and deposition costs for enforcement. The department previously received funding to do a front-end compliance review, which is where we are right now in the process. And as we've discussed in the past, federal mental health parity is extremely complex. It's a whole process that we've never had to do before, classifying benefits into the various categories, looking at the cost-sharing requirements and any utilization review and other non-quantitative limitations that the plans may have. So if the plan can't show it's in compliance, then we ask them to do a corrective action plan. And at this point, I'll tell you that no single health plan has completed the whole process. In fact, none of the plans filed complete and thorough information from the beginning. We had a 70-page document that we asked them to fill out, and it is very complicated. But we are making progress, and we anticipate that the plans will complete the initial front-end review by this September. You also asked about how mental health parity relates to the recent Kaiser report that we released. This was last month. So that was the Kaiser issue was a follow-up survey of Kaiser's behavioral health services. The original survey was done released in 2013. The focus of mental health parity is really on the cost sharing and the financial and non-financial limitations and metrics and whether they're applied similarly to medical services as they are to mental health. The Kaiser issue is strictly related to timely access to behavioral health services within the plan, and it's really a completely different analysis and issue from what mental health parity is addressing. So, any questions?
Senator?
I know that we're trying to illustrate that mental health issues are at parity with medical health problems, and I know they're trying to achieve parity, but I know it's a very difficult process with the healthcare plans. So if I have a blood pressure problem, I need to go see my doctor. I can go once a month, have my blood pressure checked, have my medications renewed, changed, altered as my blood pressure or blood fats go, anti-lipidemics. But in some of these healthcare plans, they will limit the number of psychiatric or psychological visits you can have. It's an arbitrary number that may not be commensurate with the level of care that some of our insured needs. Absolutely. So to say that we're have parity. We don't have parity. We may be striving towards parity, but how do we ensure that those that need the mental health services that we equate to be equal with these physical disabilities, and how do we really create the parity and stop the rationing, if you will, of some care that some people desperately need?
And that's exactly what we're trying to address. So yeah, as you said, in the past, there have been limitations that were different on the mental health side compared to the physical health, but that is no longer allowed by federal law and by state law historically. So what we're trying to do in our analysis is to make sure that how the plans are proposing to comply with federal mental health parity works with the laws and the way the guidance that we've gotten from the federal government. And then once we approve their plans, we're going to go next year, and I'll talk about this a little bit more when we get to that issue. 2016, we're going to survey all of the plans to make sure that what they told us they were going to do, how they were going to comply, is in fact what they're doing, and then how that's working. So I agree with you. It's a long time coming. Mental health has sort of been a stepchild in our healthcare system, and we're working hard to try to make that more equal.
The only other suggestion I would have, and you're probably doing it already, is that you need to look at the referral process. Especially when you have capitated plans, you're referring to a psychiatrist. It could be a year or 2 years worth of therapy. A general practitioner may say, I think I can take care of these. I'll just prescribe an antidepressant, and everything will be fine, when these people might need some exhaustive therapy, one-on-one. So I hope that you'll look at the referral process to make sure that it's also fair that somebody that needs some significant psychiatric care will have that care available to them.
We will, and this is a challenge too, because our help center doesn't get a lot of calls from people with mental health conditions, and so I've been encouraging their advocates, their practitioners on their behalf, if the individual themselves can't do that, to get the authorization to be able to talk to us about.
Well, we know there's a stigma problem.
Yes, we
right?
do.
That's why I've been a strong supporter of NAMI, National Association of Mental Illness, to reduce the stigma and to bring the parity that you're here advocating for, and I appreciate your answers. Thank you.
Thank you.
Thank you, Senator. Finance or LAO, any comments? We'll open up to public comment. 2 minutes, please. First witness.
Good morning, Madam Chair and member. My name is Tam Mon. I'm with Health Access California. Just want to start off by thanking the department for its extensive stakeholder engagement process. Health Access is an enthusiastic participant in these venues, and we are always happy to provide input when the opportunity presents itself. We also support the department's request for more staff to help health plans comply with the mental health parity rules. As the director described, enforcing mental health parity rules is a very complex process, and rigorous oversight is important to consumers with mental health conditions so that they can get the care that they're legally entitled to. We also believe that ongoing oversight of provider networks and formularies needs to be a priority, and we urge the committee to approve this proposal. Thank you.
Thank you. Next witness.
Carrie Sanders with the California Pan-Ethnic Health Network. We're also a stakeholder in the consumer groups with DMHC, and really appreciate the dialogue and the conversations that we've had with them over the years, and support their request. Just to say that this is a huge undertaking to get plans up to speed. It's especially important given the mental health disparities that exist with communities of color who we work with, and that intersection between mental health and physical health. And so, there is a stigma for communities to get this care, and being able to fund this position, I think these positions will be helpful in getting us to better care. Thanks.
Thank you. Next witness.
Misty Johnson with the California Psychiatric Association. We strongly support this funding request for the reasons previously stated.
Thank you.
Madam Chair, members of the committee, Louis Brown on behalf of the California Consortium of Addiction Programs and Professionals and CalNet. We provide the services to those suffering from substance use disorders, and we very much appreciate the work on behalf of the department to find parity. We know it's a complex system, but we support their request for additional staff. We believe it's important for all those individuals in the state of California suffering from substance use disorders. Thank you.
Thank you.
Madam Chair, I'm Brandon Tartaglia with Disability Rights California. We support the additional positions to help achieve parity.
Thank you. Final witness.
Elizabeth Landsberg with the Western Center on Law and Poverty, also here in support of the positions. We appreciate the department's strong consumer protections and all the assistance they provide, and specifically the work being done on behalf of those who have mental health conditions. Thank you.
Thank you very much. Senator Stone, we're going to hold this item open. Let's move to the individual market enrollment.
All right, so this proposal is for 7 permanent positions and $1.134 million for fiscal year 15-16 and about $1 million for 16-17 and ongoing to address increased workload resulting from the revised projected increase in enrollment in the individual market. I mean, to our credit, we've been wildly successful, so there's more people covered. So we need more positions to deal with their concerns and their issues. This also includes $208,000 for fiscal year 15-16 for expert witness and deposition costs for enforcement trials. Regarding the workload identified in the BCP, the department received positions in the current budget year 2014-15 to provide consumer assistance, resolve consumer complaints, and enforce managed care laws. So updated enrollment projections released by Covered California, as well as the enrollment reported to the department by licensed plans, indicates that many more Californians have and will enroll in health coverage. Originally, we had anticipated we'd regulate about 90% of Covered California's enrollment. In fact, it's about 98% of Covered California's enrollment is in DMHC regulated plans. Approximately 1.9 million consumers have enrolled in individual market plans regulated by the department as of the end of last year. And we use a conservative standard of an increase of about 3% contact rate. So we expect 3%, or the projection is 3% of the newly enrolled would contact us regarding consumer assistance. We also are requesting support for our Office of Enforcement for cases that result as we uncover violations of the law. We're also asking for 1 position for our administration division and for our Office of Technology and Innovation to address the increased workload because we are expanding our staff rapidly and we need more help, more support.
And I noted that you reclassified some positions that you had difficulty filling last year, and you think that will help expedite the filling of all these positions.
I do. Of the positions that we got last year, currently 4 are not filled, and those are the ones that have been reclassified so that we can fill those.
Excellent. Thank you. Finance, LAO, public comment.
Tam Ma with Health Access California. We support the department's request to fill these positions. Health Access supported the legislation that implemented the ACA's individual market reforms in California, and we believe it's important for the department to have the resources it needs to help consumers, many of whom are newly insured, to navigate the system. Thank you.
Thank you. Next witness.
Carrie Sanders with CPEN, and I just want to say ditto to that. Very important to have the necessary resources to help newly eligible, newly covered with questions. Thanks.
Thank you. Any questions, Senator Stone? Okay, we'll hold that item open. Thank you. Large group claims data exposure. You want to talk about the implementation of SB 1182?
Yes. So SB 1182 requires health plans to annually provide de-identified claims data at no charge to large group purchasers that request the information. Most health plans already provide some of this data to large group purchasers, but this is going to ensure that all health plans are subject to the same disclosure standards to promote a level playing field, enable purchasers to negotiate better rates, and also to assist efforts to improve the health of employees in these large groups. We're requesting 1 permanent position, a senior legal analyst in our Office of Enforcement, to address any increased workload as a result of violations of this law, which we expect will be around disagreements over the data that purchasers and plans are, discussing. So I'll answer any questions you may have.
LAO Finance. Public comment. Ms. Ma.
Tam Ma with Health Access California. We support the department's request to fund these positions. Health Access supported SB 1182 last year, which makes health premiums in the large group market more transparent by allowing large purchasers to get the data they need to better understand what's driving their premiums and have the information so they can negotiate better rates with health plans. Thank you.
Thank you, and with that, we'll hold this item open as well. Moving on to the 5th item, dental plans medical loss ratio, the implementation of AB 1962.
Yes, AB 1962, as I mentioned earlier, requires dental plans to file an annual medical loss ratio report with the department by September 30th of this year. We will make this data publicly available, and the bill also allows us to issue guidance outside the Administrative Procedures Act. So what we're trying to do is to understand how the dental plans use their premium dollars so that eventually that data can be used to determine whether or not there needs to be a standard for a medical loss ratio for the dental plans. We're requesting 1.5 permanent positions in corporation examiners and $189,000 for fiscal year 15-16 to address the increased workload related to this data analysis and collection.
Finance, LAO. Public comment.
Nisette Short with the California Dental Association. We're happy to support the department's request to make sure they have the resources to implement the bill properly, particularly ensuring they are able to do and conduct the reviews necessary to make sure that the data that is supplied to the department and to the public is accurate and thorough. So we appreciate the consideration. Thanks.
Thank you. Next witness.
Tam Ma with Health Access California. We support the department's request. Getting this information will help consumers understand the value that they're getting from their dental plans, especially when we have details about what the dental plans are spending on administration versus actual care, and it'll also help the legislature to establish a dental medical loss ratio. Thank you.
Excellent. With that, we're going to hold that item open as well. And Ms. Roulard, thank you very much for your time today.
Thank you.